Hello and welcome to the topic Urticaria in the Dermatology module. At the end of this topic, you should be able to define urticaria, explain the pathophysiology of urticaria, outline the causes and classification, describe the clinical manifestations, outline the investigations done for urticaria, discuss the principles of management, and discuss the complications as well as the prognosis. Let's get started. Urticaria is a skin lesion that appears as raised, well-circumscribed areas of erythema and edema involving the dermis and epidermis that are very pruritic. Urticaria originates from the Latin word urtica, which stands for stinging nettle. Physiologically, mast cells are immune cells that are present in connective tissues throughout the body. They have multiple functions, including vascular homeostasis, innate and adaptive immune response, angiogenesis, and venom detoxification. In urticaria, there is immune and non-immune mediated mast cell activation. Immune-mediated mast cell activation is a type 1 hypersensitivity reaction. It starts when naive, mature B cells produces IgM and IgD antibodies, and once they become activated by an antigen, B cells will proliferate. When these B cells interact with cytokines such as interleukin-4, which is modulated by CD4 T helper cells, the antibody class switches from IgM to IgE. These allergen-bound IgE antibodies will bind to high-affinity cell surface receptors on mast cells and basophils. In autoimmune disorders, the antibodies to an IgE receptor functionally cross-link IgE receptors and cause mast cell degranulation. For non-immune mediated mast cell activation, it is caused by direct non-allergic activation of mast cells by certain drugs. Physical and emotional stimuli can cause activation of mast cells too. However, the mechanism is poorly understood but possibly involves the release of neuropeptides that interact with mast cells. Eventually, mast cell activation will lead to release of histamine, bradykinin, kallikrein, and other vasoactive substances, resulting in intradermal edema caused by capillary and venous vasodilation and nucleoside infiltration. Urticaria can be acute or chronic in cause. Acute causes is due to type 1 hypersensitivity reactions, and its trigger includes drugs such as penicillins, sulfonamides, NSAIDs, and salicylates, food, more commonly shellfish, eggs, cheese, chocolate, and nuts, insect bite or sting, infections such as upper respiratory tract infection, GI tract infections, genitourinary infections, malaria, mononucleosis and scabies, and environmental factors such as pollens and chemicals, danders, dust, and mold. Chronic causes are mainly idiopathic. It is also associated with autoimmune disorders such as SLE, RA, rheumatoid arthritis, and thyroid autoimmunity. Cholinergic urticaria is caused by emotional stress, heat, and exercise. Lastly, chronic medical illness such as hypo or hyperthyroidism, amyloidosis, and polycythemia vera increases the risk of chronic urticaria. So urticaria is classified based on its onset, whether it's acute urticaria, which occurs less than 6 weeks and may progress to life-threatening angioedema or anaphylactic shock in a very short period. It is often gone within hours to days. And chronic or recurrent urticaria lasts more than 6 weeks, presenting with daily or episodic wheals. They are further classified into chronic spontaneous urticaria and chronic inducible urticaria, which include cholinergic, solar, heat, vibratory, and aquagenic urticaria. Chronic and recurrent urticaria should be referred to a dermatologist for further evaluation and management. Patients with urticaria will present with reddish swelling of various shapes and sizes all over the body. With angioedema, there will be changes in voice and difficulty in breathing. The skin lesions are raised and palpable. It can be linear, annular, or arcuate. The lesions are separate by normal skin but may coalesce rapidly to form larger areas of erythematous raised lesions that blanches with pressure. The lips, tongue, or larynx might be swollen as well. Wheeze can be heard if there's narrowing of the airways, and additional signs are dependent on underlying medical conditions. If there is hepatitis or cholestatic liver disease, there will be scleral icterus, hepatic enlargement, or tenderness. With autoimmune thyroid disease, thyroid may be palpable. Joint examination may reveal arthralgia and arthritis if there's underlying rheumatoid arthritis or SLE. So the most iconic clinical manifestation of urticaria is palpable raised erythematous skin lesions. Acute urticaria is diagnosed clinically. For chronic or recurrent urticaria, further lab investigations are required to find out the cause. A full blood count shows raised eosinophils and if there is parasite infections and drug reaction. Acute phase reactants such as ESR will be elevated in urticarial vasculitis and autoimmune disease. If autoimmune thyroid diseases are suspected, thyroid function tests should be done to rule out hypo or hyperthyroidism. Raised anti-nuclear antibody could indicate urticarial vasculitis or SLE. For suspected rheumatoid arthritis, rheumatic factor can be investigated, although it is not highly sensitive. Hepatitis B and C are associated with cryoglobulinemia, which is associated with cold-induced urticaria and urticarial vasculitis. Hence, hepatitis serology tests can be done. For urticarial vasculitis, skin biopsy can be done if the diagnosis is unclear. Histology will show neutrophilic infiltration with fragmentation of nuclei, and this is known as leukocytoclasia. Other investigations include challenge testing to identify triggers. For physical urticaria, cold, pressure, heat, UV light, and visible light can be tested. Prick or radioallergosorbent assay test can be done for contact urticaria and skin prick if suspected food allergy. Patients with urticaria should be transported to the emergency department if signs or symptoms of life-threatening allergic reaction such as angioedema or anaphylactic shock develops. 0.3 to 0.5 milligrams of intramuscular adrenaline should be given if angioedema occurs. For individuals with associated bronchospasm, nebulizer salbutamol will help in relieving it. First-line medication for both acute and chronic urticaria is second-generation antihistamine, which includes fexofenadine and loratadine, desloratadine, cetirizine or levocetirizine. First-generation antihistamines such as diphenhydramine and hydroxyzine can be added if symptoms are uncontrolled. Oral glucocorticoids are given for acute urticaria. In adults, 40 to 60 milligrams daily of prednisolone should be given for 5 days. In children, the treatment is about 1 milligram per kilogram per day for 5 days. The control of chronic urticaria may be achieved with omalizumab, a type of monoclonal antibody. For refractory cases, topical therapy with 5% doxepin cream or capsaicin can be prescribed. Acute complications of urticaria are life-threatening, which includes angioedema and anaphylaxis. Chronic urticaria can result in worsening of quality of life and have a great impact on emotional aspects of individuals. Individual wheals will typically clear up within 24 hours without treatment. However, angioedema may take up to 72 hours to resolve. Urticaria may progress to life-threatening angioedema and/or anaphylactic shock in a very short duration of time. Although chronic urticaria clears up in most cases, 15% of them continue to have flare-ups of wheals at least twice weekly after 2 years. Individuals with urticaria have better prognosis if there is an identifiable trigger, while unidentifiable trigger will lead to poorer prognosis. So to summarize, urticaria is a skin lesion which appears as red, raised, well-circumscribed areas of erythema and edema involving the dermis and epidermis that are very pruritic. Urticaria is caused by mast cell activation, either immune-mediated or non-immune-mediated, which causes release of histamine, bradykinin, kallikrein, and other vasoactive substances resulting in intradermal edema. Acute urticaria is a result of type 1 hypersensitive reaction, while chronic urticaria is mostly idiopathic but can be associated with autoimmune diseases, cholinergic, and chronic medical illness. On physical exam, there will be erythematous raised palpable swelling of various shapes and sizes of the body. In serious cases, there might be angioedema and anaphylactic shock. Acute urticaria is diagnosed clinically, while various investigations might be needed to find underlying causes of chronic urticaria. Acute urticaria should be treated as acute medical emergency if it is associated with angioedema and anaphylaxis. Second-generation antihistamine is the first-line medication for both acute and chronic urticaria. Second-line treatment includes prednisolone, omalizumab, and topical therapy. Individuals with urticaria should avoid triggers if identifiable. We have come to the end of this topic. Thank you.